Hello, everybody. I'm Richard Oehler, and Division of Infectious Diseases. Sorry about the typo there. That's very sloppy. With the Morsani School of Medicine, I always like to put that in. So today we're going to talk about a disease which has matured over the last 10 years. Now, depending on our level of involvement in medicine, where we are in our training, and so forth, we either may remember this disease very well, or we may think we know it and maybe not know it as well as we should. But nevertheless, West Nile virus over the last 10 years has joined the limited list of encephalitis viruses that we all need to be aware of and we all need to suspect at a certain time of the year. So, talking about 10 years ago, how many of us remember this period in American history where there was a lot of paranoia? And I couldn't believe this. I mean, this was so surprising, so shocking, and of course, many of you think I'm talking about Al Qaeda. I'm actually talking about the dog that made 60 million as a model. That kind of struck me before anything else. But nevertheless, society has changed very much since that time, and America's next top dog model remains to be seen. So, talking about the history of West Nile virus, I think it's important to remember that this is a relatively old virus, but one that we really became aware of at the turn of the 21st century. It really emerged from obscurity in 1999 in New York. Some of you may remember that. It produced 62 cases of encephalitis and 7 deaths. And the means of importation was not initially known. What we do know is it started in the New York area and then spread across the country. And as it spread, there's been very little subsequent genetic evolution. But cases have now been reported in most states across the U.S. and even Puerto Rico. So many of you may know that West Nile virus is a Flavivirus, and it's a single-stranded RNA virus with 11,000 nucleotides. And it's been associated with causing the Flavivirus, that is, causing human disease in 3 main categories. The hemorrhagic fevers. Who can name a hemorrhagic fever Flavivirus? Dengue fever, right? So dengue is a Flavivirus that causes yellow fever as well. Encephalitis viruses such as Japanese encephalitis virus and St. Louis encephalitis virus. And then it's also a cause of febrile illness, and West Nile virus can cause a febrile syndrome. There are 3 phylogenetic clusters that these viruses are categorized under: those with no known vector, those that are tick-borne, and those that are mosquito-borne. And among the mosquito-borne ones include several of the common encephalitis viruses that we all know, like Japanese encephalitis, St. Louis, and West Nile virus. Now, humans are not an amplifying host. Primarily, this is seen among bird viruses, and so we're incidental hosts. We're unfortunate bystanders who get exposed. Now, West Nile virus was called West Nile virus because it was found in the blood of a febrile woman in the West Nile district of Uganda in 1937. And up until recently, it was a well-characterized virus associated with not just humans, but also birds and other vertebrate animals, mostly in Asia, Eastern Europe, and Africa. And interestingly, if you pull up this reference, which I list the reference on the bottom, it was actually thought to be a promising cancer therapy in the 50s. But when they utilized West Nile virus infection, what was interesting is the encephalitis rate was quite high, which probably made it a poor cancer therapy, 11%. And patients had a lot of neurologic symptoms and prolonged viremia. And what was interesting was the virus was noted to have persisted longer in the organs than in the serum. So this is a virus that tends to disseminate in a widespread fashion, and its presence can persist in the peripheral organ tissue, including the brain, for a prolonged period of time. So before 1994, it caused these sporadic cases of febrile illness and neurologic complications mostly in Africa and Eurasia. I've listed several places, including Israel, where there were multiple outbreaks. There was a notable outbreak in 1957 that had many cases of CNS disease. South Africa in 1974. And then in 1974, something changed. Call it the sort of the tipping point of the virus, or migration patterns, or other factors. And there have been a widespread number of outbreaks in many places since 1994, including parts of Europe, Russia, and the former Soviet Union, Israel, and both the United States and Canada. And its main presence in the U.S. has been over the last 12 or 13 years. So the American outbreak, those of you who were along in your medical careers to remember it, in 1999, began in College Point, Queens. And here's a newspaper where it notes, this is from Staten Island, where it notes West Nile virus shows up in Dongan Hills mosquitoes. And the exact method that it was introduced to the U.S. is not well known, but it's believed to have arrived in either an infected bird or mosquito in the New York area. It then caused this outbreak in the New York area, and later spreading to New Jersey and Connecticut. And it was associated with the appearance of all these multiple dead birds and encephalitis in dogs, cats, and horses. And by the end of the 2001, there were 149 West Nile virus infections, including 18 deaths. And just think about that period of American history, 2001, the year of 2001, where we were dealing with a horrific terrorist attack and a episode of bioterrorism, and then this simultaneous spreading of West Nile virus. It was an exciting time for infectious disease. So what did West Nile virus do over the first 7 years of its existence? Well, here's the neuroinvasive disease incidence map for 1999. You see the green areas representing any West Nile virus activity located mainly in the tri-state area. 2000, you saw a emergence to certain areas south as the birds migrated southward, and then a lot of distribution over New York State and parts of New England. This is 2001, where it first emerged in Florida. The red circles, the red dots are the greatest level of activity here, so you can kind of track this across the U.S. over mostly 2002 and 2003. 2003, we saw a great predominance of cases in the Midwest, and as time went on, you saw the disease peak in the Midwest and then become more prevalent along the coasts. So this is West Nile virus activity in 2011 during last year's season, and human disease cases are in the boldest green color. And as you can see, there were a couple of cases in southeast Florida, and then non-human activity along our coast of west central Florida. And so how does the CDC keep track of West Nile virus as well as other encephalitis viruses? Well, they have this thing called ArboNet, and if you go on the CDC website, you'll see that the CDC conducts this active surveillance using this tool, and they've done so over the last 12 years. And it combines reports from human medicine, veterinary medicine, and their national surveillance system. But because West Nile virus is relatively a challenge to diagnose, you have to suspect it and you have to send the appropriate serology. It's not likely overreported, it's more likely to be underreported. And so you can log on to the Florida, the Department of Health for Florida, and you can look at their week-by-week surveillance system for encephalitis disease in sentinel animals. And sentinel animals are usually chicken sources, but they can also be horses as well. So far over the entire history of West Nile virus in the U.S., there have been almost 29,000 confirmed and probable cases, and about 41% of these cases have involved the more serious form, which is neuroinvasive disease with West Nile. So as I spoke about a moment ago, West Nile virus has this transmission cycle that mainly involves bird reservoir hosts, and mostly these are what are known as passerine birds, like crows and blue jays, those sorts of birds. And so what happens is this time of year, the cold time of year, and of course we've had a very mild winter season, but birds normally have a migration pattern, and the mosquitoes, particularly the mosquitoes that carry West Nile virus, which are known as the Culex mosquitoes, typically hibernate by hiding out in warm places. Now, what are warm places? Usually like sewers, underground grating and pipes and stuff. They stay there basically for the cold part of the season, and then when the temperature warms up, all these mosquitoes come out. And we know that mosquito populations can be affected by a number of things. Typically the level of rainfall, standing water, and also the ability of state and local health departments to control the mosquito population. So all that controls how many mosquitoes are out there. So once the warm time of the year comes up, the Culex mosquitoes come out of their hibernation, and they attack mostly birds, and then the birds carry West Nile virus. Some of them have persistent viremia, and they're bitten by other mosquitoes, and the pattern continues. And other birds aren't as hardy, and they die from West Nile virus. So that's why when West Nile virus was fully, in its earliest stages where it was spreading across the country, a common sight you would see would be a lot of dead birds in a community where there was a lot of West Nile virus activities. These things would be, in some cases, literally fallen out of the sky with West Nile virus infection. So if this young lady here on the upper right happens to be out and gets bitten by a Culex mosquito infected with West Nile virus, she will become an incidental host. And the same is true with other animals like horses. So as I say here, the major mosquito vectors are in the north, it's Culex pipiens. Here in the south, it's Pipiens quinque fasciatus. And if you see here at the top, that's a Culex mosquito. In the middle, that's a passerine bird. I think that may be a yellow-breasted warbler. Who knows? Any bird people around here? No? Okay. And this is interesting. I found this online. This is a horse affected with West Nile virus, essentially with a paralysis. So they've got the horse kind of suspended there from a brace because the horse is unable to carry its own weight as a result of a neurological disease. Now, you can get West Nile virus not just from mosquito bites. You can also get it from other ways. What are some other incidental ways? This might be a board question. Some other ways you can get West Nile virus. You can get it from transfusions. But nowadays, in the last few years, the local blood banks have gotten very good at screening for West Nile virus infection. You can also get it from transplanted organs. You can get it transplacentally. There are other modes as well. Anything that involves basically exposure to blood can transmit West Nile virus. You can also get it from transplanted organs. I think there was a case of a corneal transplant where someone was exposed. Things like that. So what are the major clinical syndromes associated with West Nile virus? And I'll make it simple here. There are three syndromes. Syndrome number one is you're asymptomatic, and that's a majority of cases. About 3/4 of West Nile virus exposures are asymptomatic. So if you go out in the general population and you do serology, you'll find a whole lot of people who are West Nile virus positive who never had symptoms. Approximately 25% have a febrile illness. So this may be somebody who in September or October comes down with a fever. Maybe they had a lot of outdoor exposure and the disease runs its course. Generally speaking, it may be accompanied with a rash. We'll talk about in a second. But generally, the patients with West Nile fever generally tend to do pretty well. And now the last syndrome is very rare, about 1 in 140 cases. These are the people who develop West Nile virus neurological disease. And that can be a range of symptoms, from encephalitis to meningitis to even acute flaccid paralysis, kind of like what we saw with the horse a couple slides ago. So let's do the math here. If there have been approximately 12,000 cases of neuroinvasive disease over the last few years, and 1 in 140 develop neurologic disease, that means there's between 1.6 and 3.1 million total infections with West Nile virus. It's just that most of them are asymptomatic, and it's really the neurologic disease neuroinvasive disease cases that we tend to diagnose. Now, why do you get neuroinvasive disease? Well, there's some susceptibilities that increase your likelihood of getting severe neurologic disease. Now, here in Florida, we have a lot of elderly people, right? So there's no wonder we have more neuroinvasive disease, because our population tends to be older, and advanced age is one of the most important risk factors for severe neurologic disease. But there's also a significantly increased risk of infection in patients who have hematologic infection, conditions, I should say there, not infections. So if you have hematologic malignancies and so forth, that increases your risk. Cancer and chemotherapy, and transplant patients particularly are 40 times more likely to develop neuroinvasive disease if they get exposed to West Nile virus. This is something that we need to tell our transplant patients, especially at certain times of the year. And interestingly, CCR5 deficiency may increase the risk of severe disease as well. It's been found. So let's talk a little bit about West Nile fever. What does that involve? Remember, this is the second of the three clinical syndromes associated with West Nile virus infection. So West Nile fever causes the majority of the symptomatic infections. Remember, that's about roughly 25%, because the number that develop neuroinvasive disease is very small. It's usually a self-limited illness. People get symptoms that may include meningeal symptoms, headache, malaise, fatigue. They may get back pain and an abrupt high onset fever, sometimes associated with nausea and vomiting. This rash I'll talk about for a second may occur after the onset of fever. And unfortunately, some patients develop persistent fatigue even after the acute illness. And some patients have a very mild manifestations of West Nile virus infection associated with the fever. They may have a low-grade fever, and I suspect that's the majority of cases. How many of us have not felt well one day, we develop a little bit of a fever, next day we feel better, and we say it's a 24-hour flu. This is a patient with the rash associated with West Nile virus. Usually occurs when patients are starting to feel better, they get a rash, and it tends to occur in patients with West Nile fever. As a matter of fact, if you have this rash, it's generally associated with a better prognosis than if you don't have it, because it's less common in the neuroinvasive disease manifestations. Usually associated with the chest, back, and arms, and goes away after a few days. West Nile virus CNS disease, however, can be potentially much more serious. It can be an encephalitis, meningitis, or a flaccid paralysis, or even a mixed distribution of those. You get meningeal signs, fever, headache, meningismus. That can include photophobia or nuchal rigidity. You may get cranial nerve palsies. We'll talk about the typical pattern of the CSF in just a second. Sometimes that requires hospitalization, and sometimes patients have a persistence of a headache and fatigue, and they may have other more long-term morbidity that's associated with this disease. Again, the severity may range from mild confusion to coma and death, and as far as the associated neurologic manifestations, I'll talk about those in just a second. So these were the reported cases of neuroinvasive disease last year with West Nile virus. So we can see in Florida there was a few cases, mostly reported on the Atlantic side of our state. Again, on this side, we tended to have more sentinel reporting of cases in animals rather than human disease. But a lot of West Nile virus neuroinvasive disease, as you can see here, is either sporadic or it's still centered along the coasts. And I have to suspect that may have something to do with the migratory patterns of birds because of the bicoastal predominance, and also in Florida where birds tend to migrate as well. That's speculation on my part. So if you get somebody who has extrapyramidal symptoms during mosquito season, that may be a clue for West Nile virus. Those extrapyramidal symptoms may include a coarse tremor, Parkinsonian features, myoclonus, and also you want to suspect it in anybody who has asymmetric acute flaccid paralysis, which should definitely be a warning sign and sometimes can be misdiagnosed with something else. And they may have cranial nerve palsy, seizures. Optic neuritis is also associated with the condition. Now, unfortunately, a lot of patients with this neuroinvasive disease get these very debilitating chronic sequelae. And there was a study that showed that about 54% have symptoms that are longer than a month, and the majority missed work for a median of up to 16 days. It's going to be very debilitating, particularly for the elderly patients. And patients may have prolonged fatigue, they may have memory impairment, balance problems, headache, weakness, and so forth as a result of their infection. So it's really more the debilitating features of West Nile virus that can have a prolonged impact for those who get the neuroinvasive disease. So when they talk about the other iceberg, this is a slide from the CDC a few years ago. Think about the fact that you have that small percentage of people with acute illness who are really more obvious, and then under the surface you have people who have perhaps been exposed to West Nile virus who have more long-term effects. And if the disease isn't originally diagnosed, no one's going to really suspect what their long-term neurologic sequelae may be due to. Now, what is the differential diagnosis of encephalitis syndromes in Florida? This is important for you to remember. The major encephalitis diseases in Florida, of course, are St. Louis encephalitis, West Nile are the big two, but occasionally you have Eastern equine. Eastern equine, of course, much more serious. I mean, when we have Eastern equine encephalitis in Florida, it's definitely something you hear about in the media, and because of its generally severe manifestations, it provokes usually the health departments to take additional precautions and advisories for Floridians. Venezuelan encephalitis, less common but can occur in Florida. So think about those different encephalitis conditions in Florida during the appropriate times of the year. So you definitely want to have a clinical suspicion for West Nile virus in anybody with unexplained neurologic symptoms, fever, encephalitis, meningitis, or flaccid paralysis during mosquito season, which is generally speaking, encephalitis season is the late summer. The late summer. We're talking like September for the most part. You don't see a lot of encephalitis cases in May, June, or July. It generally tends to be the end of the summer. You want to be aware, however, that in tropical places like Florida, theoretically you can have year-round transmission. Now, this is a subject of confusion. How do you diagnose West Nile virus? Well, the most readily practical way of diagnosing West Nile virus is with specific serology. So in a febrile patient with suspicion of West Nile fever, there's a test called a West Nile virus IgM MAC ELISA. And generally you want to collect it but within 2 weeks of symptom onset. Sometimes you can collect it too early, which is why you always want to think about acute and more convalescent serology. But the West Nile virus IgM MAC ELISA of serum is what you order in a patient with suspicion of West Nile virus fever. If you have somebody with CNS disease, you want to obtain an LP and send it for a West Nile virus IgM serology. Now, why is the IgM useful in the serum? Does anybody know? Excuse me, in the CSF. Why is it significant to see IgM in the CSF? Why does it signify neurologic disease? It's because IgM antibodies are too large to cross the blood-brain barrier on their own. You generally have to have CNS disease in order to develop antibodies in the CSF. So it suggests that they have neuroinvasive disease. Were you going to say something, Yuli? No? Okay. Now, generally, those are screening tests. If you want to order a confirmatory test, you order what's known as a West Nile Virus neutralizing antibody titer, or NAT. And generally, you want to order an acute and convalescent serology specimen. So if you see a fourfold rise in the titer of the West Nile Virus NAT test, it confirms acute infection. You have that change in the serology over time, in the titer rather. There is a West Nile Virus PCR that's available, but it's of limited utility because the viremia that occurs with West Nile Virus tends to be transient and low level. So this is a disease really diagnosed acutely by serology. Patients can have prolonged IgM antibodies in the serum. So just because you're West Nile Virus IgM positive, it doesn't necessarily mean that you have acute infection, right? To have acute infection, you need to have acute and convalescent serology with the NAT test, and you need to show a rise in the titer. And that's why you do that confirmatory test. Now, the other thing is if you've been exposed to yellow fever or Japanese encephalitis virus vaccines, you can have a false positive ELISA, and the ELISA also cross-reacts with other flaviviruses. So if you've had St. Louis encephalitis virus or dengue, you may also develop this positive ELISA for West Nile virus. So that's important to keep in mind. Also, you want to make sure you take that history and see if maybe somebody has been traveling in the Caribbean, as they're prone to do from here, and whether they have risk factors for dengue or one of the other flaviviruses that cause encephalitis. So generally, when you do an LP in a patient you suspect of West Nile virus, you see CSF pleocytosis, usually with a neutrophilic predominance. You may see elevated protein and glucose. In studies, the mean CSF nucleated cell count is around 200 roughly, and you may see plasmacytoid lymphocytes as well as a presenting feature. Now, how about treatment? Unfortunately, here this reminds me of that Simpsons episode where Homer Simpson, his doctor tells him, "You're in luck. We can tell you what we have. We can tell you what you have. We just can't do anything about it." That's the thing. We can diagnose this, but in terms of treatment options, they tend to be more supportive. So, unfortunately, there have been some different therapy investigations, but only really one controlled study done to date with results that weren't that ideal. They've looked at such treatments as alpha-2b interferon and ribavirin. The alpha-2b interferon treatment was based on in vitro and animal model data and 2 anecdotal cases. The ribavirin had in vitro activity, but was not found to have efficacy in an animal model and in human subjects. And they actually looked at IVIG, and that showed no benefit in a single randomized placebo-controlled trial. So generally, these patients get supportive care. If they have encephalitis symptoms or seizures, their treatment is supportive. If they have fever, again, their treatment is supportive as well. So that leads us to prevention, and of course, an ounce of prevention is worth a pound of cure, right? Did I say that correctly? If I didn't, my apologies. So you want to make sure that you advocate personal protection measures and awareness among patients at those times of the year. Yeah. Mm-hmm. I did actually mention the PCR. Yeah, and generally speaking, I think the problem with the PCR in the CSF, it may relate to the low-level viremia, but also I think that the viremia tends to be more transient. So the thought is it's easier to detect antibodies to IgM in the CSF. I'm not aware of a practical use of the PCR. Have you diagnosed a case with a PCR before from the CSF?
We had a case of TGH, if I'm not mistaken, and I
Mm-hmm.
believe it was a PCR.
Mm-hmm.
I'll have to double check.
Yeah, and that brings up an important point about, a common question that we get is, how do you order West Nile virus serology or West Nile virus tests? Of course, they go through the state health departments. So generally speaking, if you suspect a West Nile virus case, you notify the state health department. They do the testing, and if they need to refer the case further to the CDC, they have the capability to do that. There may be some PCR tests, but again, I think you have to question a single PCR value, and to my understanding, serology is still considered the gold standard over the PCR. So, but if we can chat about whether that has changed. I'm not aware that it has, but these things are always changing. So just getting here to prevention again. Letting your patients know about protection measures. How many times do we really talk to patients about mosquito repellents and personal protection with regard to mosquitoes in the summertime? There are blood donor screening programs, and there have actually been some animal vaccines, including 4 equine West Nile virus vaccines now licensed, and a live attenuated virus chimeric vaccine was shown to be effective in monkeys, but human vaccines are unlikely to be available for several years. And so we're still prevention is going to be the most important thing, but unfortunately that prevention won't include vaccines. So my summary here, remember that we've had a now 13-year history of West Nile virus infection. It's really become more of a low-level type of disease, which can occur in tropical climates at any time of the year, but really more is of highest prevalence during encephalitis season, which is in the late summer. And you can have a wide variety of clinical manifestations. Again, most people have asymptomatic disease, followed by a febrile illness, followed by neuroinvasive disease. It's usually self-limited if it's West Nile fever, but you can have significant prolonged symptoms. West Nile neuroinvasive disease tends to occur among the elderly and immunocompromised, can have severe manifestations and prolonged sequelae. The gold standard of diagnosis is by serum and CSF serology, and again, treatment is largely supportive. And maybe if I give this talk again in 5 years, we'll have a West Nile virus vaccine that's available, and I suspect it won't really be offered to everyone, but really people who are at higher risk. Kind of like similar to what many of you may remember, there was a Lyme disease vaccine offered a few years back, which ultimately was withdrawn. But the idea was, if you're at risk for exposure, maybe you want to consider this, particularly if you're one of the groups of patients who are likely to have more severe disease. And with that, I will take any questions.